Hello everyone, a very warm good evening to everybody. I hope you are all doing well and you are all taking care of yourself. And I know you had a great medicine class and you are now ready for the remaining part of the chest X-ray. So are you all set to go ahead? Are you all set to start, learning about chest X-ray further? Yes, and I'm sure you are. I'm sure you are. Okay. So once you are all set, what we will do is I'll just give you a plan that we have so that you know what we have done and what we will do in the times to come. Okay. Let me just share my screen. So this is what we have done so far. If I take a table, we have done basics of CT scan, basics of MRI, and we have done neuroimaging. And we have started with the chest X-ray. I am making a box in front of each of them. And in the first three, I'm putting a tick mark. Okay. Because these are the topics that we have done. And this is the topic that we are yet to do. This is called as, at the end of the class, I will talk about this more. This concept is called as making a checklist. Okay. So this is how we will always in my class, I'll keep telling you what all has been done, what we are going to do now and how, and after that we'll keep changing the topic. This concept is called as checklist. Okay. This entire concept is called as checklist and I will teach you how to make one for your own self as well. Okay, we'll talk about it in the end of the class today. Just remind me if I forget. At the end of the class, we will discuss how to make a checklist for yourself. Okay, everybody set? Okay, so once you're all set to study further, without wasting more time, I will ask you a surgery question that you have already studied in your class. Let's see if you can answer. What is the first step in evaluation of a patient with blunt abdominal trauma? Okay. What is the first step in evaluation of a patient with blunt abdominal trauma? The question is first step. How do you evaluate a patient with blunt abdominal trauma? What is the first thing that you do? Think of it and answer. So this is one of the most important concepts. Every year it has been asked in AIMS exam, PGI exam, JIPMER exam, NEET exam. This is like a short question, beta. Short question. Okay. And the answer to this question is fast. Okay. And I'll show you how I will link up fast and the chest imaging. Give me just 5 minutes to make sure that you understand. The fast stands for focused assessment with sonography in trauma. Okay, everybody understands? So this was a question that was asked this year in your AIMS exam. What is the full form of the word fast? Full form of the word fast is focused assessment. Better please stop typing. I am seeing many of you are doing mistakes. Okay, so I will tell you what is the correct answer, beta, but just listen to me. First step for evaluating a patient with blunt abdominal trauma is FAST. FAST stands for focused assessment with sonography in trauma. Now, if I change the question and I say, what is the investigation of choice for blunt abdominal trauma? Then what will you mark? Okay. If I change the question and I ask you, what is the investigation of choice for blunt abdominal trauma? First question was, beta ji, first step. Now the question is IOC. So the investigation of choice for blunt abdominal trauma is a contrast enhanced CT. Investigation of choice for blunt abdominal trauma is a contrast enhanced CT. Everybody clear? Everybody understands? Okay, but please notice, okay, please notice this can only be done if the patient is stable. Okay, that means investigation of choice for blunt abdominal trauma is CCT, but can only be done if a patient is hemodynamically stable. If unstable, then the first step and IOC are same, that is fast. Everybody understands and follows? If the patient is hemodynamically unstable, then the first step and investigation of choice is same as fast. Okay, now please understand. That means first step for evaluating abdominal trauma, even if the patient is stable or unstable, is fast. But the investigation of choice is different. Investigation of choice in a patient who is stable will be contrast enhanced CT. Unstable, it will be fast. Everybody understands? Okay. So, beta, laparotomy is not the investigation. So, laparotomy, you will proceed if the fast is positive, you will proceed to laparotomy. Let me explain to you. Just give me 1 more minute to explain myself, because I will make just simple points in front of you, not hi-fi points. Okay, very simple. Fast is done by keeping the probe in. Okay, so this is the abdomen of the patient. Okay. Suppose if this is the abdomen of the patient. Okay, so where do you keep the probe first? In fast, okay, in fast, you keep the probe first in the epigastrium. Very important question. Ultrasound probe is first kept at the epigastrium. Okay. Now try and imagine if I keep the ultrasound probe in the epigastrium, okay, here, and I tilt it upwards, I will look for cardiac tamponade. So remember, in abdominal trauma, we still need to rule out cardiac tamponade because it can lead to rapid death. So remember, first you keep the ultrasound probe in the epigastrium to rule out cardiac tamponade. Very important future question. Okay, very good. In epigastrium, you keep it below your xiphoid process. So it can also be written as sub-xiphoid. That is the first position. Second, we keep the probe at the right flank. Second, we keep the probe at the right flank. When I keep the probe in the right flank, right side you have the liver and the kidney. So we try to look between the liver and the kidney. We try to look between the liver and the kidney. That is called as hepatorenal pouch or Morrison's pouch. Because we know if in abdominal trauma, any organ ruptures, there will be blood in the peritoneum, hemoperitoneum, and it will go into the dependent recess called as the Morrison's pouch. Very good. Then we keep the probe in the left flank to assess any obvious splenic injury or any blood in the linorenal recess. So we want to look for blood around the spleen and the recesses around the spleen. Number 4, you keep the probe in the pelvis. to look for pelvic blood collection. This is what is called as fast. This is what is called as fast. And if they use the word e-fast, that means extended fast. You keep the probe in the right thorax and the left thorax. So that means in extended fast, you also evaluate for thoracic trauma, including things like pneumothorax and hemothorax. Okay. Extended fast means that we will also look at thoracic evaluation to assess for blood in the thorax as well as air in the thorax in a patient with trauma. Everybody understands the concept? Okay. So once you understand my concept here, this is very, very important one-liners. Now let's come back and understand the concept with a visual. Okay. Let's see an answer. Let's see the first image of the day and let's try to understand why am I teaching you this image. Now this is how an ultrasound image looks like. Gradually in my class I will show you more and more ultrasound images. Don't worry. This is the first ultrasound image that we are looking at. This is the liver. This is your right kidney. Are you able to see it? So you can see in this ultrasound image, okay, I'll show you the slide again. Look at this ultrasound image first. There is liver and you can see the right kidney. Okay, what I want you to do is I want you to look at this dark area between the liver and the spleen. This dark area is fluid. This dark area is fluid. Normally, you should not be able to see any fluid in this area. If you see dark area, that means there is fluid. Now my question to you is, in patient with trauma, what fluid will be there in the peritoneum? You will have blood. So there will be hemoperitoneum. So how will you write your report? This will be, if you find blood in the peritoneum on fast, we call it fast positive. This is a question from last year's AIMS exam. Okay, I'll teach you basics of ultrasound. Don't worry, I'll talk about basics of ultrasound in detail later on. Here, I just wanted to show you that in my last class, I showed you pneumothorax on X-ray. Today, I will also teach you pneumothorax on ultrasound. But gradually, I will go back and teach you about the ultrasound as well. Don't worry. Okay. So can you see there is a dark area between the liver and the right kidney that is fluid. In a patient with trauma, this fluid should be blood and we will label it as fast positive. So what do we mean by fast positive? It means presence of hemoperitoneum. And this is the image that was there in November AIMS exam. Okay, they said look at this fast image and tell us what is it. The answer was fast positive. We're looking at fast positive. Everybody gets it? Okay. Now we will talk about ultrasound a little later, but let's understand one more question. I'm giving you a question. You just need to say, this will be asked in the next AIMS exam. You just need to say true or false. Ultrasound is more sensitive than chest X-ray for pneumothorax assessment. Is it true? Is it false? Okay. Clear? Ultrasound is more sensitive than chest X-ray for pneumothorax. Is it true? Is it false? What do you think? The answer is true. So that was the point that I wanted you to understand, that in extended fast, to detect pneumothorax, we are utilizing ultrasound. Everybody clear? Okay, so this line is actually true. Whenever it will be asked, most people will get it wrong. Okay, this line is true. Now let's understand how we will see the pneumothorax. The questions that I am telling you now have been asked every year. They are asked in the AIMS exam. Don't do them wrong. If you please listen to me very carefully. The answer, this line is true, and I can see most of you got it wrong. This is the future AIMS question. Okay, listen to me now. In ultrasound, in thorax, we use a mode called as M mode ultrasound. In extended fast, in thorax, we use a mode called as M mode ultrasound. M mode is sensitive to detect movement. M mode is going to show you the movement. Okay, it's going to show you the motion. Okay, now listen to me and answer. Suppose, okay, suppose this is my, okay, let me just zoom myself in. Okay, suppose this is your chest wall and this is where you have your pleura. So with respect to the chest wall, the pleura is showing sliding movement. Okay, so that means with respect to your chest wall, the pleura should have sliding movement. Okay, now listen to me and answer. If there is a pneumothorax here, what will happen? If there is a pneumothorax here, the lung is collapsed. Now you will have no sliding movement here. Okay, let's understand it again. What I'm saying is, okay, what I'm saying is, in a normal person, you should see sliding movement on ultrasound at lung pleura interface. But if you have pneumothorax, this movement will be absent. Okay, everybody understands? And that is why, beta Shinchan, do you understand now why ultrasound in chest X-ray topic? Because for pneumothorax that we started in yesterday night, actually speaking, ultrasound is better in trauma to detect pneumothorax than a chest X-ray. That is the important thing. Okay, now see, listen to me. Okay, listen to me. Very important, beta. So now you understand that why suddenly sir is talking about ultrasound while he was supposed to talk about chest X-ray, because the topic is pneumothorax. Okay, now please see with me. If I do a M mode ultrasound, in M mode ultrasound, if there is no movement, you will see flat lines. So at the chest wall, you will have flat lines because there is no movement. But in a normal person, at the lung pleura interface, the dots, you will see movement, and the lines will be distorted because of the movement happening. While if there is pneumothorax, the lung pleura interface cannot be reached and you will see only flat lines. Are you clear? Everybody understands? Now see with me. See with me again. And I am sure you have studied this in your surgery class also, but I want to repeat. This is what I mean to say here. This is a M mode ultrasound. Look at the normal appearance here. Can you see the flat lines at the chest wall? There is no movement happening at the chest wall. And in the lungs, because of movement, the lines are distorted. It looks as if this entire area is a beach and these are the waves. This is called as sea shore appearance. While if you have a pneumothorax, okay, if you have a pneumothorax, then there is no movement at the chest wall, no movement below it. So you will only see flat lines, flat lines, flat lines like a barcode, also called as stratosphere sign. So yesterday I taught you the most important sign of pneumothorax on a chest X-ray is visceral pleural line sign. Today I am telling you the most important sign of pneumothorax on ultrasound is barcode sign, also called as stratosphere sign. While if the ultrasound is showing seashore sign, that is normal. Everybody, flat lines represent no movement. There is no movement. So at least now you understand why it is happening. You might have studied this in your surgery also, but I wanted you to know the why behind it. That it is because of sliding movement in a normal person that happens at the lung pleura interface. In pneumothorax, that is absent. That is why in a normal person on M mode you see seashore appearance, while in pneumothorax on M mode you will see barcode appearance. And you saw this question has been repeatedly asked in AIMS exam, NEET exam. It is very, very important. Okay. Everybody? Yes? Yes. So let's try and understand that fast is done only in trauma, beta. It's done only in trauma. Okay. Now, once you are clear, two more lines to understand. Can we do ultrasound in a patient with acute respiratory failure as well? Just like we are doing ultrasound in trauma, we can even do ultrasound in acute respiratory failure. There it is called as blue protocol. Then you don't use the word fast. The word fast is used only for abdominal trauma. Here we will say bedside lung ultrasound in emergency. Okay. Similarly, today in ICU, we even use ultrasound in acute circulatory failure. Then we use the word false protocol. That is fluid administration limited by that is called as fluid administration limited by lung ultrasound. So let us again revise. Very important. Okay. चेस्ट वॉल बेटा हम इधर से वेव जा रही है, चेस्ट वॉल की इस तरह कोई मूवमेंट नहीं हो रही, इस दिशा में, इस डायरेक्शन में कोई मूवमेंट नहीं है. So chest wall, with respect to the chest wall, there is movement at the lung pleura interface in a normal person. So these are the potential questions to remember in future exams. Okay. The question is, remember, in blunt abdominal trauma, the ultrasound protocol used is fast. In acute respiratory failure, the protocol is blue. In acute circulatory failure, the protocol is false. Okay. False stands for fluid administration limited by lung ultrasound. Blue called for bedside lung ultrasound in emergency. Okay. Everybody follows. Okay. So now with this, we are now finished with the discussion about the pneumothorax. Very, very important. But because I had to use the word fast, so I explained a little bit about fast so that you understand the words that I'm speaking. Everybody follows? Everybody follows? All the chota bachas? Okay. So the images where you are writing this is, if you notice in your workbook, you will find this image, and some written word written there fast. Okay, this is where you will write this all. Okay, now once you understand this, I will give you a x-ray to solve. Again, you might have seen this x-ray in your surgery class as well, है ना? बेटा फॉल्स भी अल्ट्रासाउंड है और ब्लू भी एक प्रोटोकॉल है अल्ट्रासाउंड का. जैसे फास्ट एक प्रोटोकॉल है, फास्ट इज अ प्रोटोकॉल दैट वी यूज इन ट्रॉमा. Blue is a protocol to be used in respiratory failure. False is a protocol to used in circulatory failure. Fluid administration limited by lung ultrasound. False is fluid administration limited by lung ultrasound. Okay. Now let's see an answer. Okay, let's see an answer, beta. Any one of you can answer. If this is your chest x-ray, what structure is my arrow pointing at? That is diaphragm. This is also diaphragm. Okay, so now my question is, why we are able to see the diaphragm? We are able to see the diaphragm because air in the lung is outlining. Okay, now tell me why you are able to see the central tendon of the diaphragm. Okay, the central tendon of the diaphragm is visible because you have air in the mediastinum. We will call it pneumomediastinum. So remember, now earlier we were reading and understanding about pneumothorax. Now I am teaching you about pneumomediastinum. If there is any esophageal rupture, okay, okay, so suppose you have in the mediastinum hollow viscous like esophagus, trachea. If they perforate, you will develop air in the mediastinum. This appearance is called as continuous diaphragm sign. So very frequent question in your exams and very frequent visual. Remember this, continuous diaphragm sign is a sign of pneumomediastinum. Okay, सेंट्रल टेंडन है डायफ्राम का, जो पिंक कलर के एरो से मैंने मार्क किया, वो नहीं दिखना चाहिए. वो इसलिए दिख रहा है बिकॉज द एयर इन द mediastinum is outlining it. Everybody understands? Okay, now second. Now suppose you have pneumomediastinum in a child. What will happen in a child? Air in the mediastinum will also outline the thymus. Okay, everybody understands? Now let me show you this x-ray of a child. I want you to look at your screens carefully. Only one word we need to learn, but let's look at the screen and understand. This white thing that you see in the child, outlined by air, is his thymus. Can you see in this x-ray, there is the right lobe of thymus and the left lobe of thymus, both outlined by pneumomediastinum. This is called as, you might have studied again this in your surgery class also, spinnaker sail sign. This is called as Spinnaker's sail sign. After the spinnaker sail that is used in boats, we call it Spinnaker sail sign. Now revise. Name two signs. Name two signs of pneumomediastinum that we have studied so far. We saw the continuous diaphragm sign and we saw the spinnaker sail sign. Okay, so let me show you the spinnaker sail sign again. Can you see now? I'm zooming it and trying to show it to you. I am trying to show you the outline of the thymus. The reason we are able to see the outline is because it is outlined by air. Now understand, if there was no pneumomediastinum, you would not see the complete outline of mediastinal structures. If I'm able to see the complete outline, that means it must be outlined by air. Everybody understands? वही चीज एक्सरे पे दिखती है जिसको हवा आउटलाइन कर रही है. Okay, अब if I can see the borders of the thymus, that means it is outlined by air. That means there is pneumomediastinum. Okay, yes. Okay, now once you are clear, another point to understand is in your thorax. Okay, in your thorax, the esophagus starts in the midline, but then it starts to go towards the left and it meets the stomach. Do you remember? Esophagus starts at the oral cavity, but then it goes gradually it goes towards the left and meets the stomach. And in surgery, they might have talked about esophageal perforation syndrome called as Borhave syndrome. So often you see leak at the lower end of esophagus. If there is pneumomediastinum, especially due to esophageal perforation, you will see air outlining the aorta and left diaphragm. Okay, this triangular pocket of air is called as Nucleus V sign. Okay, you might have studied all of this in surgery also. So remember now. Yes, can you see this? This is your this sign is called as Nucleus V sign, and I'm again repeating for you. All I have shown you now in this flashcard is these are X-ray signs of pneumomediastinum. So how do you identify pneumomediastinum on X-ray? If you see diaphragm in its entire continuity, then we call it continuous diaphragm sign. If you see the thymus outlined by air, spinnaker sail sign. If you see air between the aorta and the left diaphragm, again this is a sign of pneumomediastinum. It is called as Nucleus V sign. Okay, everybody understands? So initially I was trying to show you where the esophagus is. This is where you have the esophagus beta, and this is where you have the stomach. Okay, so now do you understand why Nucleus V sign is being seen on the left side? Because the esophagus is towards the left side. If it perforates, the lower end perforates, you develop Nucleus V sign. Nucleus V sign is seen between the aorta and the left diaphragm, not on the right side. Okay, are you clear? So these lines are, okay beta, so let me explain to you. This is where you have the descending aorta, and this is where you have the diaphragm. So the air is actually outlining the border of the descending aorta and the left diaphragm. That is why it is forming like a V. This is called as Nucleus V sign. Which wire, beta? Which wire? I did not show you any wire in this. All I made was, beta, you're not listening to me. All I showed you was where is the esophagus. This is where the esophagus is located, and this is where the stomach is located. Okay, so this is the reason why Naklarios V sign forms on the left side between the aorta and the diaphragm. Okay, these wires, these are nothing but those simple ECG electrodes which are used in ICUs and all. They're nothing to worry about. They're just these wires are ECG electrodes or some electrodes that they might be using in ICU. There's nothing to worry about. Okay, everybody clear? Okay. Now, once you're clear, so this question was pneumomediastinum. So let's understand what we have done so far, so that when I move forward, you should be able to understand. So far, I have shown you how to look at a chest X-ray of pleural effusion, empyema, pneumothorax, but we also saw pneumothorax on ultrasound, and we saw pneumomediastinum. Okay. Everybody understands? Yes? Okay. Yes. Once you are clear, beta, see, all these signs can be seen in same patient also, or you may not see them together. It is all variable. It depends on the amount of air which is leaking from the esophagus. Now, once you understand the concept so far, now I will introduce to you two small common words to understand. Once you understand them, I will be able to teach you those words better. Okay, I will be able to show you those words on an X-ray. In chest X-ray, we often use the words like, have you heard of them before? Collapse and consolidation. On chest X-ray, we often use the word collapse, consolidation. Okay, now see if you can answer. Okay, collapse matlab there is loss of aeration in a lung lobe along with volume loss. Okay, so whenever I use the word collapse on a chest film, the meaning is collapse means ओके लॉस ऑफ एरेशन यानी उसमें हवा नहीं है और वॉल्यूम निकल खत्म हो गया ओके एवरीबडी फॉलोज नाउ टेल मी बेटा लेट्स सी इफ यू कैन आंसर इट इज जस्ट लाइक आई वांट यू टू इमेजिन अ टायर पंचर a truck tire has punctured what will happen loss of air loss of volume collapse okay now tell me from your basic understanding why would collapse happen okay why would collapse happen in a chest film anybody collapse in lungs can be because of bronchial obstruction okay collapse of a lung lobe can be because of bronchial obstruction cause of bronchial obstruction in a child if the question says child you should think of anybody if you have a lung lobe collapse in a child what will you think of you will think of foreign body okay and another cause of collapse could be a tumor okay so remember collapse the most important cause to consider is bronchial obstruction which could be as urgent as a foreign body in a child or a tumor in a chronic smoker okay but do not forget collapse of a lung lobe can also be compressive can you name any disease which leads to compressive collapse of the lung Compressive collapse is due to pleural pathologies like if you have massive pleural effusion or pneumothorax. The presence of air or fluid in the pleura compresses the lung and causes a compressive collapse. And third cause is called as cicratesial, or we might use a word fibrotic collapse. This is the kind of collapse that you see in patients with tuberculosis. Remember, in TB, because of tubercular infection, the lung is damaged and then that area is becoming fibrosed. So that area, because of fibrosis, will also become collapsed. Okay. Now, if any one of you can think and tell me, because before I show you the X-rays, I just want to form a concept. What will happen to the trachea and mediastinum in collapse? Beta, बताएं. What will happen to the trachea and mediastinum in collapse? They will be pulled towards the disease. They will be pulled towards the disease. I am sure you can understand now. If there is normal lung, it will having air, it is black. Collapse will be white. Not only it will be white, you will also see evidence of volume loss. The trachea will be pulled towards the side of the disease. The heart and the mediastinum will be pulled towards the side of the disease. Okay. Yesterday, some of you were asking what is push, what is pull. बीमारी की तरफ ट्रेकिया का आना is pull, उससे away जाना is push. Okay, what about consolidation? What is consolidation? Consolidation क्या होता है? Now imagine now, suppose I take a tire of a truck. In that tire, I fill up sand. Now what will happen? What will happen? Sand will replace the air in the tire. So now there will be no air, but there will be no volume loss because something else has been added there. So consolidation is when things like fluid or pus replaces the air in the lung. So again, it will be white, but there will be no volume loss. Okay. So trachea and mediastinum will remain central. They will not be pulled or pushed. Everybody understands? Okay. Are you clear? Okay. Now understand now, pleural effusion में mass effect होगा, उसके नीचे lung collapse हुआ, फिर भी वो mass effect इतना ज़्यादा था कि it was pushing the. So remember, collapse के अंदर, you are getting confused. The predominant effect of collapse is pull, but the predominant effect of pneumothorax and pleural effusion is push. समझ पा रहे हैं बेटा? समझ रहे हैं? बेटा रटिए मत, आप रटने की तरफ आ जाते हैं. सर उन्होंने तो ये बताया था. इट इज वेरी लगता है कि बच्चे हैं बेटा. ध्यान से देखिए ना बेटा. सो इफ यू हैव समथिंग फिलिंग अप योर थोरैक्स, अंडरलाइंग लंग कोलैप्स होने के बाद भी इट विल कॉज मास इफेक्ट, इट विल कॉज पुश. आर यू क्लियर विद दिस? बट इफ यू ओनली हैव कोलैप्स, इट विल कॉज पुल. Okay, now let's see if you can understand. Now once you understand the basics, let's understand more basics, and then we'll gradually come to disease. Now let's understand where is the right upper lobe. Okay, this is how on a chest film, this is where your right upper lobe should be. You have to tell me, why is the lower border of right upper lobe, why is the lower border of right upper lobe appearing smooth? Right upper lobe का lower border इतना smooth क्यों है? Okay, see, the only smooth margins in a chest film are pleural. So below your right upper lobe, we have a pleural surface called as the horizontal fissure. Because it is a pleural surface, it is very sharp and smooth. Are you clear? So lung smooth nahi hoga, pleura smooth hogi, and so the pleura forms a fold below the upper lobe, which is called as the horizontal fissure, and that is your horizontal fissure, which is a pleural surface. This is where your right upper lobe is. Okay. Now, okay. So I see some students have asked कि why consolidation में volume loss क्यों नहीं होगा? बेटा consolidation में alveoli से हवा निकल के वहां पे कुछ और fluid आ गया है, हमने कोई fluid pus आ गया, exudates आ गए. So now in effect the volume is maintained, the air is replaced by something. Just like if I put sand in a tire, what will happen? The sand will replace the air from the tire, but the shape and volume of the tire will be maintained. That is the reason. Everybody understands? Okay. Now everybody understands. Now see an answer. This is right upper lobe. Now see the second part. This is your middle lobe. This is your right middle lobe. Okay. A lot of X-ray finding will be based on this anatomy. Listen to me carefully. Okay. This is your right middle lobe. And this is your right lower lobe. Okay. The sharp margin that you see here is your oblique fissure. Remember your first year, they taught you all this in first year? Okay. Now, are you able to see with me that the middle lobe is anteriorly placed, lower lobe is posteriorly placed? Are you clear? So they are actually overlapping each other if I look from front, but when I go from the lateral view, middle lobe aage, lower lobe piche. Middle lobe is an anteriorly placed structure and lower lobe is a posteriorly placed structure. Okay. Okay. Now somebody is asking fibrosis और consolidation में कैसे फर्क करेंगे? Again बेटा, you need to understand fibrosis. कहीं पे भी बेटा fibrosis होगा. क्या करता है fibrosis? Fibrosis का shrinking. So that lobe will become small and it will pull the trachea towards it. So fibrosis will lead to collapse. It is called as sacratesial collapse of the lobe. Do you understand? जहां fibrosis होगा, चीजें shrink हो जाएंगी, छोटी हो जाएंगी. Okay? Now see an answer now. Are you clear now? So this is where you have your upper lobe, middle lobe, lower lobe of the right side. Okay, I will show you the X-rays. Don't worry. We are just understanding it. Then I will show you the X-ray. Okay. Now please see an answer. Okay. So far we have learned collapse should pull the trachea towards the disease. Consolidation will have no push or pull. Pleural effusion, pneumothorax will push the trachea and mediastinum away from it. Okay, now is it okay? बेटा प्लूरल इफ्यूजन में बेटा आई थिंक आपने नहीं देखा, जब प्लूरा में पानी भर जाएगा तो अंडरलाइन लंग को क्या होगा? That will get collapsed. So that is called as a compressive or a passive collapse. Okay. Everybody understands? Okay. Now, once you're clear. So let's start evaluating the first X-ray together. So this was only to make sure that you understand. The key is, okay, I'm sure you have read about consolidation in your pathology also. जब वो उन्होंने बताया था, the lung becomes like gray hepatization, red hepatization. I don't know, आपने पढ़ा था कि नहीं? But let's see. Let's try and understand. Okay, let's see the first X-ray and try to understand beta. Okay, let's see an answer. Okay, now tell me, this is your trachea. Okay, this is your trachea. Okay, this is your right side. This is your left side. Are you able to find out where is the disease? Are you able to see a disease? Yes, this is a opacity. Okay, can you see opacity? Yes. So there is a opacity in the okay. बेटा आई थिंक यू सौम्या सम यू नॉट फॉलोइंग अगर कोई प्लूरा में बीमारी होगी चाहे हवा है चाहे फ्लूइड है अंडरलाइंग लंग विल कोलैप्स एंड द एंटायर थोरैक्स विल बी फिल्ड अप विद द प्लूरल डिजीज प्लूरा में पानी है या हवा है वो उसको भर देगा okay so the underlying lung collapses that is what I meant to say okay now see so you have a problem in the right upper lobe why is the problem appearing white because there is loss of aeration. Okay, now tell me, trachea, is it pushed away or pulled towards the disease? क्या सोचते हैं? Trachea appears pushed or pulled? Pulled. Okay. Trachea appears pulled. Everybody follows? This is called as right upper lobe collapse. My question to you is, okay beta, let's see if you can answer. Why is the lower border of the opacity appearing so sharp and smooth? Why is the lower border of the opacity appearing so sharp and smooth? That must be your horizontal fissure. That must be your horizontal fissure. That means the horizontal fissure also is pulled up. This is a case of right upper lobe collapse. Okay, the horizontal fissure is pulled up, there is loss of aeration, trachea is pulled, so we have two evidence of volume loss and one evidence of loss of air. There is opacity. So we think, what about the rest of the lung? The rest of the lung appears to show compensatory overinflation. Normally your middle lobe and lower lobe would have been here, now they have gone till here, they have gone up as well because there is a upper lobe collapse, so there is a compensatory overinflation of the remaining lung. Okay, everybody follows? Okay, everybody follows. Now better don't suffer and don't use these words like suffering. I know it is difficult for everybody. Just listen to me. I will explain. Everybody understands? So the key here is whenever you have a volume loss, a lobe of the lung which is having reduced volume, the fissure will be pulled, the trachea will be pulled. Okay, so trachea is pulled towards the disease, fissure is pulled towards the disease. And so if you now recall, the normal upper lobe was supposed to be shaped like this. Okay, in this patient, the upper lobe is shaped like this. Can you see now it has become small, and that is why I am calling it as collapse. I am not calling it as consolidation. Are you clear? This is collapse. This is your trachea. If I zoom it, I'm sure you will be able to see, bachas. Please see, this is your trachea. Okay, everybody understands? Okay, very good. Now once you are able to understand, let's see the second question. Let's see if you can follow the second question. It is very, very important to understand. Okay. Oh, but just keep looking at, let us unfold things more and more, and then we will be able to understand. Okay, now listen to me and answer. If this is your trachea, this is your right bronchus. Okay, what do you see in the right upper lobe? You see a opacity on the right side. Okay, you are able to see an opacity on the right side. Okay, any one of you. Why is the lower border of the opacity appearing so smooth? Why is the lower border of the opacity appearing so smooth? This must be the fissure. But the fissure should have been here. It should be horizontal. Horizontal है ना, सीधा होना चाहिए. So if this is the fissure, what has happened to the fissure? The fissure is pulled up. So what do you think we are looking at? Again, I think I am looking at right upper lobe collapse. Again, I think I'm looking at right upper lobe collapse. But my question is, if it is a collapse, why is the central part of the fissure, which I'm marking now, why is the central part of the fissure pushed down? Why is the central part of the fissure pushed down? That means there must be something heavy. There must be a heavy weight disease sitting here. Do you understand? So that means in the center we have a heavy weight disease which is causing bronchial obstruction as well as pushing the fissure down. What could that be? That could be a tumor. Okay, so that means if there is a right upper lobe collapse due to a bronchogenic tumor, the horizontal fissure becomes like this. This was described by a man called as Golden, hence we call it as Golden's S sign. Hence we call it as Golden's S sign. Okay, now I'm sure you're able to understand now gradually. Once you will see gradually, I'll show you pneumonia also. Don't worry. I think some children are getting worried. I'll show you. Don't worry. Now, please see with me. Now I'm making a flashcard. Both of them are right upper lobe collapse. The only difference is the first one was only a collapse. Second one is collapse plus tumor. Okay? Now do you understand this? Okay. Now some student has asked a very good question, that why are the lungs appearing so dark? The lungs of this patient are appearing dark because both the lungs are hyperinflated. Not only are the lungs hyperinflated, the diaphragms are flattened. If you notice, beta, you remember we saw the diaphragm was shaped like a dome. Here the diaphragm is flattened. Name a condition. Yeah, that is what we are asking you. Name a condition in which you have hyperlucent, hyperinflated lungs and flattening of the lung and flattening of the diaphragms. That condition is called as emphysema. Or we use the word COPD. So this patient also has emphysematous variety of COPD. Clear? Now, beta, let's see if you can answer. This patient has a lung tumor as well as emphysema. Can you now think like Sherlock Holmes and tell me something about this patient? Some character about this patient that we are now suspecting? He has emphysema as well as bronchogenic tumor. Why would somebody have emphysema as well as bronchogenic tumor both? Probably he must be a smoker. Okay, probably he must be a smoker. Are you clear? Everybody understands? Now, why this is not pneumothorax, beta? Had it been pneumothorax, you should see the underlying collapsed lung with a sharp outer margin called as the visceral pleural line sign. Here we are not able to see any such line. And now you can see how in radiology we go step by step and we understand what is happening and how the things are working. Yes. And I want you to know, all the children, that is correct. Some of your writing, smoking kills. Yes, definitely it does. And all the youngsters, especially if you're a doctor, you should never smoke. Because if you smoke as a doctor, that becomes ironic. Okay. Let's see the next X-ray and solve it. Okay. Okay. In the next X-ray, please tell me, okay, in the next X-ray, what I want you to tell me is, where is the disease located? So in the next X-ray, you can see there is a opacity. Okay. Where is the opacity located? So there is a triangular opacity. So this is the shape of the opacity. This is how we call it as a triangle. This is like this. Okay. My question is, let's see if you can answer. Where the disease is abutting the cardiac border, at that area, the cardiac border is obscured. We can no longer see the cardiac border along the opacity. So there is a triangular opacity obscuring the cardiac border. Okay. There is a triangular opacity obscuring the cardiac border. Okay. Let's see if you can answer here or not. Have you, any of you, have you ever heard a sign in your clinics or in your hospital as, did they ever talk about this? Silhouette or silhouette sign, did they ever talk about this? Okay. So what does this mean? The silhouette sign means, let's understand it here and then I will apply it. Any mediastinal border, everybody please write down. Any mediastinal border can be obscured only by pathology which is in direct anatomical contact. I will zoom it, don't worry. The silhouette sign says any mediastinal border can be obscured only by pathology which is in direct anatomical contact. Everybody understands? Are you able to see this here? Very important question. Okay, so I want your full attention. It's not easy. Chest X-ray is not an easy topic, so I want you to focus. Okay, more you focus, better you will learn. More you remain diverted, difficult it will become. Okay, so let's try to understand it further. Okay, now tell me. Now imagine now. Okay, listen to me. I'll just remove the screen here and I will go back. Okay, now please see. If this is my sternum, right behind my sternum, I have my heart. Behind the sternum, you have your heart. Okay, this is where I have my middle lobe, and this is where I have my lower lobe. Lower lobe is posterior, middle lobe is anterior. This is where my heart is. Now imagine now, right heart is just behind the sternum, anteriorly placed. Middle lobe is anterior, lower lobe is posterior. Now imagine and tell me which lobe is anatomically touching the heart. Which lobe of the right side is touching the heart? Anyone? Which lobe? It is the middle lobe which is anatomically touching the heart because both of them are anterior. So that means If the cardiac border is obscured, that means this disease must be a middle lobe pathology. Are you clear with this or not? This is right middle lobe collapse. Are you understanding this? This is called as the silhouette sign. The silhouette sign says if an opacity is obscuring the cardiac border, it must be in the right middle lobe. Are you clear? It's very, very important, beta. Very important. They will ask you this in your college viva also. They will say, if a disease is obscuring the cardiac border, where is the disease located? You need to mark the answer as middle lobe, right middle lobe. Everybody gets it? Yes. So this is the concept behind it. But my question is, this X-ray looks a little strange. Look at the clavicle of these patients. Okay, this X-ray looks a little strange. Please look at the clavicle of this patient. Okay, I will talk about collapse and consolidation later on. Just listen to me. Okay, just follow my flow, please. Now tell me. Okay, because if you're constantly suspicious and thinking, please listen to me first. Let me first lay down your concepts and then I will show you. बेटा हार्ट की बीमारी कैसे हो सकती है ना बेटा, इधर तो लंग में बीमारी दिख रही है ना, हार्ट में ऐसा क्या होगा जो इसे ट्रायंगल से यहाँ आ जाएगा? दिस इज द डिजीज. Okay, consolidation, there will be another sign that I will teach you about consolidation, that is called as air bronchogram, and once you know that, then we will come back to this discussion. Okay, in consolidation there will be another sign to look for. Okay, and I want you to look at the clavicle in this patient. The clavicle in this patient, they look high up. Why? Now try and understand how this X-ray has been done. Let me explain to you. Okay, suppose this is your X-ray machine and this is your patient, and this is where you have the X-ray film. Okay, I will explain it to you. Try and imagine, suppose I am the patient. Okay, let's try to remove the screen and make it full screen. Okay, now suppose I am the patient and suppose I have a film behind my back. So where is the X-ray film? X-ray film is behind my back. The X-rays are coming from the front and I am standing like this. I have made my spine like this. Okay, so this position is called as, anybody knows? This is called as lordosis. So this is called as lordotic view. Okay, so what happens is, okay, listen to me beta, listen to me. It's an AP view, but it has been done in a lordotic position. Okay, it has been done in a lordotic position. Now please concentrate beta, concentrate. The problem is many people are unable to concentrate when they are sitting at home. They are thinking that these are holidays going on. These are not holidays going on. Beta exam aa jayenge, hai na? इसी तरह से exam ही आ गए तो क्या करेंगे, है ना? So please listen to me carefully. If you keep your hands on your clavicle and you make yourself lordotic, you will feel the clavicle going up. So actually speaking, the X-ray that we are looking at is a lordotic view. Why do we need a lordotic view? Okay, why do we need a lordotic view? Listen to me, everybody. Hai na? Listen to me. Better see. Listen to me, everybody. Suppose this is your lower lobe. This is your upper lobe. What is hidden between the two lobes? It is the middle lobe, which is hidden between the upper and the lower lobe. Now, when I make the patient lordotic, what opens up? Okay, what opens up? It is the middle lobe which opens up. So that means the question that I'm trying to tell you here is, best X-ray for middle lobe pathologies is, what will you mark? Lordotic view. Best X-ray for middle lobe pathology is lordotic view. And second thing you can directly understand is, when I'm making the patient lordotic, the clavicles are going upwards. So the apex is also exposed. So second thing that you can see better in a lordotic view is apex. Especially you might get such a X-ray done for tubercular patients. Are you clear? Are you clear? Okay. So lordotic view, okay, is done for middle lobe disease as well as for apical pathologies. Okay. Film पीछे, rays आगे से आ रही है, patient lordotic position में. This is how this X-ray has been done. Okay, that is why it is not looking like a routine PA view. And why we did? Because we wanted to open up this middle lobe pathology and we wanted to see it properly. So middle lobe disease is best evaluated by lordotic view. Everybody understands? Okay. So you must have, suppose I do a routine X-ray, I have some suspicion, I want to look at it better, you will do a lordotic view. Everybody understands? Yes. Once you are able to follow this, now see the left side. Okay. Now please see, this is your left upper lobe. Okay. When I look on the left side, okay, when I look at the left side, I'm able to see that this is your left upper lobe. Why is the left upper lobe, okay, listen to me and tell me, why is the left upper lobe larger? And what is this tongue-like projection? Do you see this tongue-like projection from the upper lobe? In Greek and Latin, the tongue is called as lingula, so this must be the lingular segment. So left upper lobe is larger than the right lobe because you do not have a horizontal fissure, you have a lingular segment hanging from the upper lobe like this. Are you clear? Okay, very good. Now see this here, and this is your left lower lobe. My question is, let's see, any of you can answer my question here is, let's see, where is the left middle lobe? Left का middle lobe कहाँ है? होता ही नहीं. So there is no horizontal fissure, there is no middle lobe, only upper lobe and lower lobe. So actually speaking, if you look at this X-ray, this is your upper lobe, this is your lower lobe. Are you clear? On the left side, you don't have, okay, you don't have a middle lobe, you have upper lobe, oblique fissure, lower lobe. Okay. So let me ask you a question. If you have left upper lobe collapse, if you have left upper lobe collapse, how will you identify it on an X-ray? Okay. Let's see an answer. I'm sure you will be able to follow. Now, suppose there is left upper lobe collapse. What is collapse? I've already taught you. Collapse means loss of air, loss of volume. So what will happen to the upper lobe? Upper lobe will become white because of loss of air and it will become small. So the upper lobe will become opaque as well as small. Let's try to see it here. So if there is a left upper lobe collapse, this is how it would look like. If there is a left upper lobe collapse, it will become small, it will become white. Now, tell me now, what will happen to the oblique fissure? अगर लेफ्ट अपर लोब कोलैप्स होगा तो ऑब्लिक फिशर, ये वाला जो फिशर है, इसको क्या होगा? कोलैप्स क्या करता है बेटा? टेल मी, व्हाट डू यू थिंक द कोलैप्स डज? कोलैप्स विल पुल. Oblique fissure will be pulled anteriorly. ये oblique fissure ऐसे आगे की तरफ पुल हो जाएगा. Okay. Now tell me, when the oblique fissure is pulled anteriorly, what will happen to the lower lobe? What will happen to the lower lobe? The lower lobe will start developing compensatory hyperinflation. The lower lobe will become हाइपर इन्फ्लेटेड. ठीक है. लंग में इफ द वन एरिया बिकम्स स्मॉल, द अदर एरिया विल एक्सपैंड टू कवर अप दैट स्पेस. द लोअर लोब विल डेवलप कंपनसेटरी हाइपर इन्फ्लेशन. Okay, so are you clear with this much? Okay, now let's look at an X-ray of left upper lobe collapse. Left upper lobe collapse is very difficult to diagnose on an X-ray. Okay, now I want you to understand and I want you to look at this area. ठीक है, यहां पे देखना है बेटा, बताना है. So the area that I have marked, okay, everybody focus and answer. The area that I have marked, is that area opaque or is it hazy? जो हिस्से को मैंने मार्क करा क्रॉस लगा लगा के, ये सफेद है कि हेजी है? सो एट द बेस्ट वी कैन से इट लुक्स मोर हेजी, है ना. ऐसा नहीं है ना, इट इज नॉट एग्जैक्टली व्हाइट. वो उतना व्हाइट है नहीं, उसके पीछे से हवा भी दिख रही है. इट इज हेजी. Do you agree? Do you agree? Okay. Now imagine now, let's see if you can understand. Suppose I keep the X-ray film here and these are your X-ray beams. Okay, these are your X-ray beams. Listen to me beta, it's tough, okay? It's very tough, but let's see if you can understand. ठीक है बेटा, थोड़ा मुश्किल है, लेकिन जब एमडी करोगे तब भी मुश्किल ही लगेगा. मुश्किल चीजों से डरना नहीं है. When I have told you in the beginning of my last class, that in my last class, if you remember, that intelligence means tackling tough things and trying and understanding them. Intelligence का मतलब है कि मुश्किल चीजों को, मुश्किल problems को समझें. Okay, but what happens is if we become afraid of difficult things, we will not be able to learn. Okay, imagine now, listen to me, everybody listen to me. If this is your X-ray film and these are your X-ray beam, usually a collapse should appear white, opaque. But left upper lobe collapse is hazy. Why? Because the image that is formed by the collapse and hyperinflated lower lobe put together. Do you understand? जो एक्सरे पे इमेज बन रही है, कोलैप्स के कारण उसको व्हाइट हो रही है, लेकिन उसके पीछे जो इतना हवा है वो मिलने के कारण that appearance is now appearing hazy. It is not really opaque. Everybody understands? Everybody understands? Everybody understands? Yes. So now we understand left upper lobe collapse will not be as opaque as other collapses. Do you agree? भाई जो राइट पे देखा था तो it was totally white. Left upper lobe collapse will not be as white as we thought. Okay, but now tell me, what is the hint that is now in this X-ray which is telling me that there is a collapse present? भाई यहां तो सिर्फ हेजीनेस है, लेकिन क्या दिख रहा है? I want you to look at the trachea. I want you to look at the trachea without thinking about medicine. जो सामने वो देख के बात करते हैं, ये क्या है? प्रत्यक्ष को देखना है, सामने है क्या बेटा? We just need to see what is there. क्या ये trachea? What do you think? Trachea. Trachea appears pulled towards the disease, which is giving me a hint that there is a collapse. Okay. Trachea is pulled. Very good. Very good. Trachea is pulled. Now, if I take you back to a normal X-ray, let's see if you can answer. Let's see if you can answer from our normal X-ray discussions. Now, imagine, suppose I have left upper lobe consolidation. अगर मुझे left upper lobe में pneumonia हो जाए, ठीक है? So you will have consolidation here. So if you have left upper lobe consolidation, will you see aortic knuckle? क्या aortic knuckle दिखेगा? नहीं. Aortic knuckle will be obscured. on X-ray, to see a mediastinal structure, it should be outlined by air. अगर लेफ्ट अपर लोब में डिजीज है तो अयोटा दिखनी नहीं चाहिए क्योंकि उसका बॉर्डर ही नहीं मिलेगा. एवरीबडी अंडरस्टैंड्स? एवरीबडी अंडरस्टैंड्स दिस और नॉट? ओके, yes. Do you agree that if it is a left upper lobe consolidation or pneumonia, the aortic knuckle should be obscured? Okay, very good. Now I will ask you the most tough question that I have asked you in my entire class. है ना? इससे मुश्किल मैंने आपसे नहीं पूछा. Let's see if you can answer this question. है ना? बहुत मुश्किल है. MD करने में भी मुश्किल लगेगा बेटा. है ना? Now see an answer. Can you see the aortic knuckle here? Can you see the aortic knuckle here? Okay, let's see if you can answer. Are you able to see the aortic knuckle here? Yes. How? Now the challenge here is, and that is very important, in a patient with left upper lobe collapse, aortic knuckle is actually visible. It is outlined by hyperinflated sickle-shaped superior segment of the lower lobe. Okay, लेफ्ट अपर लोब जब कोलैप्स होगा तो लोअर लोब हाइपर इन्फ्लेट करता जाएगा और उसका सबसे सुपीरियर सेगमेंट अयोटा को बॉर्डर दे देता है. सो लेफ्ट अपर लोब कोलैप्स, aortic knuckle is actually outlined by hyperinflated sickle shaped superior segment of the lower lobe. Okay, so यहां aorta दिख रही है क्योंकि वो lower lobe उसको बॉर्डर दे रहा है. In German, air is called as Luft. In German, air is called as Luft, and sickle is called as Sichel. So this appearance is called as Luft-Sichel sign, seen in left upper lobe collapse. Okay, are you clear? So why is left upper lobe collapse difficult to identify? Because it is not as wide as you were expecting to see. Other lobe collapses were appearing opaque. यहां पे देखते हैं तो it looks hazy. The only evidence are the trachea is pulled towards the disease and the aortic knuckle is visible. So had it been a pneumonia, the trachea would not have been pulled and aorta would not have been visible. So this is now telling me this is not left upper lobe pneumonia, this is left upper lobe collapse. Are you clear? Are you clear? Okay. Now, and you can actually think of it and think that when we say the airline Lufthansa, Lufthansa also means air. Luft means air. Air. Like in India, we have Air India. In Germany, they have Lufthansa, is one of the airlines there. So this is Lufthansa airline. Are you clear? Okay. Sichel means sickle. Sichel मतलब sickle, sickle shaped है. ये जो aorta के साथ में, I will try to outline it for you. ये जो sickle shaped हवा से भरा हुआ लोब दिख रहा है, ये वाला, ये actually lower lobe है जो ऊपर को pull हो गया है. So because it is shaped like a sickle, we call it Sichel, Luft-Sichel. Are you clear? So it is the lower lobe which is actually hyperinflated and pulled up, and it is giving a border to the aorta. This is called as Luft-Sichel sign. Luft-Sichel sign is seen in left upper lobe collapse. Okay, everybody understands? Okay, थोड़ा सा मुश्किल है. Okay, थोड़ा सा मुश्किल है. Okay, so that is why this is the left upper lobe collapse. ये जो haziness दिख रही है ना यहाँ पे, haziness, that is a collapse. Why collapse? Sir, pneumonia क्यों नहीं हो सकता? Because the trachea is pulled and you can see the Luftsichel. These two are indicators of left upper lobe collapse. And I already promised you that left upper lobe is, okay, left upper lobe is, okay, most difficult collapse to identify on the X-ray. Okay. Yeah, it would be hazy even in a AP view also, beta. It would be hazy because दोनों चीजों से मिलके बनेगा ना इसलिए. Okay, so that is where you all you see is some haziness here. You're not sure is if it is pneumonia or if it is collapse, but you see the trachea pulled, you see the Luftsichel, and you diagnose it as left upper lobe collapse. Okay, it is difficult to diagnose things. Even sometimes MD students they miss it, but they are not supposed to miss it as a MD student, and they fail in their exams. Okay, it's very simple to know. Okay. Because when you are MBBS, I'm sure you agree, when you are in MBBS, the professors are very, very kind to you in the exams usually. But when it is MD exam, the people become more and more stringent because they feel that, they're awarding a bigger degree and then you're supposed to tell it. Okay. Now let's see if you are able to answer this. Okay. Now, after we do the next X-ray, the concept will be made. Now, after we look at the next X-ray, we should be able to make a concept. Okay. Let's see if you can answer better. Trachea. Trachea looks central. Trachea is central. There is a opacity in the right upper lobe, but the volume is more or less maintained. Okay. There is a right upper lobe opacity, but the volume is maintained. The fissure is at its normal position and the trachea is central. What could it be? This is where we start using a term right upper lobe consolidation. Okay, this is where we will start using a word right upper lobe consolidation. Okay, everybody agrees? Okay, now let's see if you can answer. Let's see if you can answer. Very, very important question. Okay, everybody listen to me, listen to me. Can you see there are some air-filled bronchi visible inside the opacity? जहां पे disease है, it is not totally white. Collapse तो पूरा white था ना. It is not totally white. You can see tubular air-filled shadows inside it. And this sign, which I will now explain to you, is called as air bronchogram. Okay. So what did we learn so far? There are two reasons why we are calling it as consolidation. The volume is maintained and you can see the air bronchogram. Everybody understands? But why we are able to see air bronchogram? Why? Okay, let's understand the why here. Suppose if this is your bronchus or a respiratory bronchus, these are your alveolar ducts and these are your alveoli. Okay, these are your alveoli. Okay. Suppose we saw the respiratory bronchiole, the alveolar ducts, and the alveoli. Okay, let's look at it in the microscopic manner. That fissure was normal. It is slightly curved, but that was normal because sometimes children they come to me and say, "Sir, horizontal fissure to ekdam seedhi line hona chahiye na." Beta, but there are no straight lines in real life. Real life, you have some curves. है ना? थोड़ा curve होगा beta. It's very, very important. Now see an answer. Very, very important to see. Listen to me. If these are your alveoli and if this is your bronchus, around your alveoli you have capillaries. In the interstitial space, you have your capillaries. Okay, यहाँ पे capillaries है. Now suppose you have a bacteria, a pyogenic infection, a pneumococcal bacteria reaching your alveoli. ठीक है, bacteria आपके alveoli में आ गया. So what will happen? What will happen is now these capillaries will dilate and they will have hyperemia and they will start leaking. That is what happens in inflammation. And when the capillaries will start leaking, they will produce exudates, leaky capillaries, exudates, bacterial fluid, exudates, inflammation. And this exudate will start filling up the alveoli, and the alveoli are all connected to each other by pores of corn. So the alveoli will get filled up with inflammatory exudates in pyogenic infections like this, and this is how it would look like on X-ray. Now imagine please try and think. If you start thinking, we will be able to do better. Okay, listen to me, beta. Listen to me. The alveoli, when they are diseased, they will become opaque, but the bronchus is air filled, तो उस opacity के अंदर बीच बीच में tubular bronchus दिखेंगे. This is called as air bronchogram. So if I now say air bronchogram is seen in mnemonic consolidation, yes or no? The answer is yes. Okay. Air bronchogram is a feature of mnemonic consolidation. Why it happens? Because the alveoli are filled up with exudates and the bronchus remains patent. Okay. Now let's see if you can answer, beta. Let's see if you can answer. Okay. Let's see how many of you are able to answer this question. Now, some of you might have heard of this, that in COVID infection also, or in pancreatitis also, in systemic inflammatory diseases, any disease which leads to massive systemic inflammatory response, okay, can lead to the lung capillaries becoming leaky. Listen to me, beta. बहुत systemic inflammation के कारण भी lung में capillaries will start leaking fluid. That is called as ARDS. Acute respiratory distress syndrome, which is a result of systemic inflammatory response that happens. Even this is one of the risk that you have with COVID infection, that you may develop ARDS. It's one of the risks because of the systemic inflammatory response it incites. Okay, so you will have ARDS. My question is, okay, so in your exam they will ask you, क्या ARDS में air bronchogram होगा? Do you have air bronchogram in a patient with ARDS? Lungs will become white because they're filled up with fluid, because the capillaries are leaking because of inflammation. लेकिन air bronchogram होगा कि नहीं होगा? Answer है होगा, because the inflammation will leak, the capillaries will leak and they will fill up the alveoli, but the bronchus will remain patent. So air bronchogram is also seen in ARDS. आप समझ आया? ARDS में भी air bronchogram दिखता है. Why? Because for air bronchogram to form, you need two things. You need alveolar opacification and you need an open bronchus. If these two things are there, the X-ray will show air bronchogram. That is where you might now start appreciating that, especially the students who are interns, post interns, now you will start appreciating कि भाई air bronchogram pneumonia में ये तो पता था, लेकिन वो एग्जाम में पूछेंगे कि भाई ये छोड़, pneumonia तो ठीक है, ये बता ARDS में होगा कि नहीं होगा? आंसर है होगा. So are you clear or not? Air bronchogram is not only seen in pneumonia. Pneumonia is a localized inflammatory process happening in the lung. ARDS is a widespread diffuse inflammatory process leading to opaque lungs, but still you have air bronchogram present. Everybody understands the concept now? Air bronchogram, the concept is alveoli should be opaque and the bronchus should be open. So once you understand this, I will give you a pediatrics question. Have you heard of a disease called as hyaline membrane disease? क्या आप में से किसी बच्चे ने सुना हाइलाइन मेम्ब्रेन डिजीज HMD इन अ चाइल्ड? Yes. Where? You heard about hyaline membrane disease in premature children, premature infants. Premature infant में उसको किस चीज की कमी है? So there is deficiency of surfactant. Premature infant में, now somebody is asking what is pores of corn. Pores of corn are microscopic channels which are connecting the two alveoli. Okay. Everybody understands? Okay. Now see, hyaline membrane disease may the child is premature born and he has no surfactant. Okay. Now tell me, what will happen to the alveoli if you don't have surfactant? What will happen to the alveoli if you don't have surfactant? Now understand, alveoli are membranous. They have an inherent tendency to collapse because of surface tension, that is called as law of Laplace. So if there is no surfactant, there is nothing stopping the alveoli to collapse, the alveoli will collapse and they will become opaque. उसमें से हवा निकल गई तो वो opaque हो जाएंगे. Okay? What about bronchus? What will happen to the bronchus in hyaline membrane disease? The bronchus is cartilaginous. The bronchus is cartilaginous, so it does not need surfactant to stay open. It will remain patent. So bronchus will remain open. So that is why in hyaline membrane disease, you will see the pediatrics people will tell you the hyaline membrane disease, you will have white out lungs plus air bronchogram. Okay. Because there is the disease of the alveoli, but the bronchi are patent, and these are the prerequisites to see air bronchogram. That is why many people get it wrong in the exam. So remember now, name 3 causes of air bronchogram: pneumonia, ARDS, pneumonia, ARDS, hyaline membrane disease. All 3 of them would show air bronchogram. Okay. What is the prerequisite for air bronchogram? There should be a disease in the alveoli and the bronchus should be open. Everybody understands? Okay. Now let's see the next question and we try to solve the next image together. Okay. देखते हैं बच्चे. Let's see if you can answer. Okay. In the next question, the question is saying a chronic alcoholic comes to you with fever and sputum production. Okay. Chest X-ray is shown to you. What could be the causative organism? Okay. I will explain, beta. I will explain the more and more concepts. Don't worry, beta. I want you to have patience. Some people want to run. बेटा भागेंगे नहीं, टीचर की स्पीड पे चलेंगे. आगे पीछे रहेंगे, टीचर से पीछे रह गए तब भी बात नहीं बनेगी, आगे चले गए तब भी बात नहीं बनेगी. You need to go with me, okay? मेरे साथ चलना है. There is no need to run faster than me or run slower than me. You need to move with me, okay? Please answer. Chronic alcoholic has fever. Where is the problem? The problem is seen in the right upper lobe. Okay, there's a disease in the upper lobe. Now, when I look at this disease, the horizontal fissure has a strange contour. Can you see in this patient, the horizontal fissure is actually bulging down. Why the horizontal fissure is bulging down? This appearance is called as bulging fissure sign. This tells me that whatever infection this alcoholic has developed must be very exudative. Listen to me, I'm explaining, listen to me. Whatever infection has happened, it has caused the upper lobe to become inflamed. There is pneumonia, but not only there is pneumonia, the upper lobe is expanded by the copious amount of exudates that is being produced here. Such exudates are seen in a pneumonia called as Klebsiella. So the answer is Klebsiella pneumonia. Predominantly seen in the upper lobe, alcoholics and diabetics. X-ray shows bulging fissure sign. Are you able to understand the question? Are you able to understand? Now please see with me. In the first X-ray, the fissure was like this. This is the normal position. So this is a routine upper lobe consolidation. We don't know why it has happened. But in this patient, we can see the consolidation is causing the bulging of the horizontal fissure down. This is seen in Klebsiella pneumonia. Are you clear with this? Are you clear? Yes, very good. Now let's go further. Let's understand now. Suppose this is your bronchus. These are your alveolar ducts. Okay. These are your alveoli. Okay. What do you think happens in a viral pneumonia or in mycoplasma pneumonia or in pneumocystis pneumonia? Have you heard of this before? Pneumocystis jirovecii? Yes. Okay. Let's see an answer. Okay. Let's see an answer. Yes, Klebsiella shows that red current jelly sputum. Very good. It can even be a tumor. But that is why if you notice, I gave you a history ना भाई अल्कोहलिक है बुखार के साथ स्पूटम के साथ आया है तो अभी हम इन्फेक्शन सोचेंगे ना that is why I want you to look at the entire history very carefully. My question is, what do you see in a viral infection, mycoplasma or pneumocystis pneumonia? In these infections, what happens is because of inflammation, the interstitium develops edema. यहाँ पे alveoli में exudates नहीं बनते. It is the interstitium, the walls of the alveoli which become swollen because of edema. Edema क्यों होगा? Inflammation में क्या होता है बेटा? Acute inflammation में क्या होता है? Edema, capillary leak करेंगी. But now the capillaries which are leaking are restricted to the interstitium. And that is what you might have studied in your pathology also, that bacterial pneumonia are alveolar predominantly, but the viral pneumonias are interstitial. Okay, everybody understands? Now I want you to focus, beta, focus, beta, focus. Huh? Look at this. Now imagine this on the X-ray. Imagine this on the X-ray. What will happen? In the X-ray, the interstitium will having edema, so it will be thickened. What will happen is this entire thing, the interstitium which is thickened will be seen on X-ray, and there will be air in the alveolar spaces. It will look like a net. It will look like a net. In Greek and Latin, the net is called as reticulum. So we will use a term reticular opacities. So only thing I want you to understand is whenever I say reticular opacity on a chest X-ray, I will mean interstitial opacity. Are you clear? I will mean interstitial. PCP मतलब pneumocystis pneumonia बेटा. Pneumocystis pneumonia कहाँ पे सुना था? कहाँ पे सुना है आपने? एड्स के पेशेंट में सुना है. अभी कोविड आने के कारण we have all forgotten all other infections, but don't forget other infections are also existent. Okay, now see an answer, beta. Let's see an answer. So let's see the X-ray here. Okay, I will show you the X-ray by zooming the film, but I want you to see it carefully. And I want you to look at the areas that I'm marking for you. Okay. Do you feel in this area that I'm marking, do you think there is some net-like, fine net-like appearance? All those crisscross lines forming a net-like appearance is called as reticular opacities. Okay, now I'm sure you are able to see after I've zoomed. Are you clear? When you see reticular opacities on a chest X-ray, you call it we think of interstitial pneumonias, interstitial infections. Okay. Now, once you're clear, I will make a question for you so that we are able to understand how all this is important for you in the exam. Is a HIV positive patient with CD4 count less than 200. HIV positive patient, CD4 count less than 200, on chest X-ray shows reticular opacities. Okay, this is a previous AIMS question. Okay, what will you suspect? What will you suspect? I will ask you the full question, but tell me, what will you suspect? You will start suspecting infection by an organism called as pneumocystis. Okay, pneumocystis gyrovesi. Okay, start thinking of pneumocystis gyrovesi pneumonia. Are you clear? Are you able to now see the word reticular is helping me? Okay, my question is, let's see if you can answer. So in the PGI exam, sometimes they ask you, will you see pneumatocele formation in PCP pneumonia? ठीक है, क्वेश्चन में लिखा रेटिकुलर ओपेसिटी तो होता है, क्या न्यूमैटोसील फॉर्मेशन होगा कि नहीं होगा? Will you see pneumatocele formation in PCP pneumonia? Yes or no? Okay. Now what happens is, you might have heard of pneumatocele. Pneumatocele are the air-filled cystic spaces in staphylococcal pneumonia. So many children, they start thinking pneumatocele to staph mein hota hai. But now they don't understand that answer is written in front of them in the exam. This is how the exams are. Answer सामने लिखा होता है. Pneumo मतलब हवा, cyst माने cyst. Air-filled cyst is pneumatocele. Pneumatocyst are seen in pneumocystis gyrovesi. तभी तो उसका ये नाम है. Correct. Okay. But many people get it wrong in the exam because they think वो याद रट के आए होते हैं. Try and imagine. So when you mug up, pneumatocele is seen in staph only, then you can't see what is in front of you. You miss out on the obvious. आप प्रत्यक्ष को नहीं देख पाते. And that is what is required. That's called as exam skill. Pneumocystis pneumonia में you will have pneumatocyl. तभी तो उसका नाम है pneumocystis. Everybody understands? Okay, now once you are able to understand this, the question is, what about lymph node enlargement and what about pleural effusion? Not seen. Lymph node or pleural effusion is not seen in pneumocystis pneumonia. So that means in a patient with AIDS, what findings are suspicious for on a chest X-ray for pneumocystis pneumonia? Reticular opacities and pneumatocyte. What is not seen? Lymph node and pleural effusion are typically not seen. Okay. Now, once you are clear, another thing I want you to remember is when we do a CT scan, PCP pneumonia shows perihilar ground glass opacities. Okay, you might have heard of this term before also, and nowadays it's a very important word to remember. Ground glass. Okay, ground glass का मतलब होता है, if on a CT scan disease is not as white as pneumonia nor as black as air, माने हवा के जितना ब्लैक भी नहीं है ना ही pneumonia के जैसा. Pneumonia से कम dense है, हवा से ज्यादा, तो we say ground glass. So we use the word ground glass opacity. Pneumatocele means air-filled cyst. Okay, so please remember, CT scan पे pneumocystis pneumonia shows perihilar ground glass opacities. What do you see in COVID-19 pneumonia? What is the CT finding of COVID-19 pneumonia? You will see peripheral ground glass opacities going on to develop consolidations which are more rounded in morphology. Okay. Very important question for this year's exams. Okay. So even in pneumocystis, you have ground glass, but this is more central, more around the hilum. While in COVID-19, you get peripheral ground glass opacities, which are bilateral with rounded morphology. These are all typical features of pneumocystis of COVID-19 pneumonia. Everybody understands? Okay. So once you are clear with this, I will now ask you another question. Okay. Let's see if you can answer. What if somebody is exposed to some dust inhalation? Okay, listen to me. Because of maybe some kind of silica exposure or asbestos or occupation, some dust he is inhaling. So what will happen now? This dust goes into his lungs every day and it causes inflammation in the interstitium. So you will have initially reticular opacities there also. So reticular opacities are not only a feature of viral pneumonia, mycoplasma pneumonia, it will also be seen in, tell me, in occupational lung diseases. Now imagine if I'm working in a coal mine or a sand mine, I'm working there for long, what will happen? So now listen to me. In acute inflammation, we had edema. Acute inflammation में edema था. Chronic inflammation में क्या होगा? Chronic inflammation में क्या होगा? Any one of you can answer, beta. What will happen in chronic inflammation? Okay, let me show you what happens in chronic inflammation. Okay, let's see if you can understand. So in chronic inflammation, you have fibroblasts which will lay down the collagen and there will be fibrosis. Chronic inflammation where there will be scarring. Okay, everybody understands? Do you agree? Acute inflammation where I told you there will be capillaries which are leaking, leading to edema. Chronic inflammation where there will be collagen, there will be fibrosis, healing. Everybody understands the concept? Yes, you are able to understand. You are so intelligent. It is so easy to teach intelligent students like you. It's so easy. All I have to do is I have to just say a word, you understand. So because of fibrosis, this area will get more and more thickened. Fibrosis, or more and more thickened, more and more thickened, more and more thickened. So the interstitium will develop fibrosis in a long-standing irritant, it will become fibrosis, and the air spaces will become smaller and smaller. So ultimately, when this develops, it becomes irreversible damage, which we call as honeycombing. Are you able to understand this? Which we call as honeycombing. Concept बना कि नहीं बना? बेटा अब सब कोई पूछ रहा है कि टीबी और न्यूमोसिस्टिस. बेटा टीबी ट्यूबरकुलोसिस विल हैव दैट एपिकल प्रीडोमिनेंस है ना. आई विल शो यू टीबी एक्स-रेज आल्सो. बेटा डोंट वरी है ना. डोंट रन बेटा है ना. भागेंगे नहीं, धीरे धीरे चलते हैं. सो देन यू सी हनीकॉम्बिंग. सो व्हाट इज हनीकॉम्बिंग? इन अ इंटरस्टिशियल लंग डिजीज, व्हेन हनीकॉम्बिंग डेवलप्स, दैट इज एंड स्टेज डैमेज, दैट इज इरिवर्सिबल डैमेज. जब हनी कॉम्बिंग हो गया उसका मतलब वो हिस्सा खत्म हो गया है, स्कार्ड हो गया है इंटरस्टिशियल लंग डिजीज के कारण, एंड इट इज इरिवर्सिबल डैमेज. एवरीबॉडी क्लियर? नाउ लेट्स सी एन आंसर. ओके, नाउ आई एम राइटिंग अ स्टेटमेंट. यू नीड टू टेल मी ट्रू और फॉल्स. ओके बेटा, आपने सिर्फ ट्रू फॉल्स बताना है, बस कुछ ही नहीं करना ही नहीं है ना. ट्रू फॉल्स. चेस्ट एक्सरे is inadequate for ILD characterization. Chest X-ray is inadequate in interstitial lung disease characterization. Yes or no? अभी दिखाऊंगा honeycombing. Okay. Chest X-ray is inadequate for ILD characterization. Yes or no? बोले बच्चे? The answer is true. That is correct. Chest X-ray is not enough to characterize interstitial lung disease. वो बता ही नहीं पाता ठीक से. अब बच्चे देखो. All we could say on the previous X-ray is that there is some interstitial lung disease. There is some, kind of, reticular opacities, but I cannot tell you how much. Is it honeycombing? Is it not? I cannot tell. Okay. Now tell me. Let's see if you can answer. Let's see if you can answer. Then, what is the investigation of choice for interstitial lung disease characterization? बोलो क्या करें अब अगर एक्सरे काफी नहीं है तो क्या करें दैट इज वेयर वी डू समथिंग कॉल्ड एज HRCT ऑफ द लंग बेटा बायोप्सी करने से पहले कुछ नॉन इन्वेजिव करेंगे ना सो इन्वेस्टिगेशन ऑफ चॉइस टू कैरेक्टराइज अ इंटरस्टिशियल लंग डिजीज इज कॉल्ड एज high resolution CT of the lung. This statement was asked last year in NEET PG as well. पिछले साल की नीट के एग्जाम में भी था. What is the investigation of choice for interstitial lung disease characterization? High resolution CT, HRCT. Everybody clear? Okay. So what is HRCT? HRCT means taking 1 to 2 mm very thin sections of the lung. Okay. Normally, when I do a CT scan of the chest or any part of the body, we try to take sections of 8 to 10 mm. एक section की thickness 8 से 10 mm. Okay. Every section is of around 8 to 10 mm thickness. But in HRCT, this thickness is 1 to 2 millimeter. And because the thickness is so thin, we are able to see the lung parenchymal abnormalities in detail. Okay, we are able to see lung parenchymal abnormalities in detail. Let's try to understand this HRCT. So this is how HRCT would look like. Let's try to understand what we are able to see. This is your heart. This is your vertebra. My question is, okay, my question is, if this is your heart, the question is, okay, the question is, are we looking at the lung base or lung apex? भाई अगर ये हार्ट है तो लंग का नीचे का पार्ट है कि ऊपर का पार्ट है? इज दिस एपेक्स और इज इट अ सेक्शन थ्रू द बेस? दिस इज अ सेक्शन थ्रू द बेस. ठीक है ना? When you take a section from at the level of the heart, it must be through the base. Now tell me. Okay, look at the page 51 in the workbook if you have. Okay. Now see, नहीं है तो कोई बात नहीं, जहां है वो देख लेते हैं. Now please see with me. Can you see at the lung base? Very good. Can you see these multiple air-filled cystic spaces? Okay, I will zoom it to the maximum. Stacked over one another. एक के ऊपर एक बैठी हुई. So can you see these multiple air-filled cystic spaces which are sitting one over another like this, one over another? एक के ऊपर एक बैठी है क्या? This is called as honeycombing. This is called as honeycombing. So that means what do we see in this patient on a CT scan? We can see basal honeycombing. Is this disease touching the pleura? Yes, honeycombing is reaching till the pleural line. This must be the area where the pleura must be. So we say disease is not only basal, it is also subpleural. I'm teaching you how to characterize on interstitial lung disease. This is tough. Okay. So if you are unable to understand, listen to me intentfully. Okay. What do you see in the CT scan? We can see basal and subpleural honeycombing. Okay. Now look at the bronchus here. Look at the bronchus here. In the area where we see honeycombing, the bronchus appears to be dilated. जहाँ honeycombing है, वहाँ bronchus looks dilated. Why it is happening is, listen to me, न्यूमेटोसील ऐसे नहीं होगा. ये तो बहुत छोटे छोटे हैं ना न्यूमेटोसील, ऐसे एक के ऊपर एक के ऊपर इतने सारे नहीं बैठे होंगे ना. This is honeycombing. Okay. Now see an answer. Okay, everybody now listen to me. Wherever you have honeycombing, that is where you have fibrosis. वहां fibrosis जहां पे, that fibrosis is pulling, that is pulling, खिंचाव कर रहा है, it is pulling the bronchus, and because of that pull, the bronchus has become dilated. We use a term here called as traction. Traction मतलब खिंचाव, traction, pull, bronchus का dilate होना, bronchiectasis. Okay. So in this patient, HRCT shows basal honeycombing, subpleural involvement, traction bronchiectasis. The history is old man who is smoker has dry cough, breathing difficulty, and pulmonary function test shows restrictive pattern. Okay. This is the history given. So you might have read about this in your physiology also, that in lungs we do a test called as spirometry or pulmonary function test, where you have an obstructive pattern, restrictive pattern. In this patient, the PFT shows restrictive pattern. Okay. If the PFT shows restrictive pattern, you need to tell me what is the diagnosis on HRCT now. Okay. Okay, any one of you. Okay, so we're looking at ILD, लेकिन ILD के अंदर इंटरस्टिशियल लंग डिजीज में अगर हनीकॉम्बिंग मिले और ट्रैक्शन ब्रोंकिक्टिसिस मिले लंग बेस पे, तो उसको क्या कहते हैं? That is where we use a term called as UIP. इस पैटर्न का नाम है UIP. What is UIP? Most common interstitial lung disease pattern called as usual interstitial pneumonia. UIP मतलब usual interstitial pneumonia. Prognosis poor. Prognosis poor क्यों होगा बताओ? क्योंकि there is fibrosis. Once you see honeycombing, that means we are looking at irreversible damage. This is called as usual interstitial pneumonia. Are you clear with this or not? Now do you understand that on history and clinical test we could suspect that there is interstitial problem because of the restrictive pattern, dry cough, smoker, but the CT scan is characterizing that okay, there is honeycombing, there is traction bronchiectasis, which is telling us that this is usual interstitial pneumonia. UIP is basal predominant. ठीक है बेटा, इसलिए यूआईपी बेसल प्रिडोमिनेंट होता है. एपेक्स में अगर ये देखते तो हम अलग कारण सोचते. Okay, very good. Now see the next picture. Now in the next question I am giving you the same history. In the next question I am giving you the same history beta, same history दे रहा हूं. Old man, smoker, dry cough, breathing difficulty, PFT is showing restrictive pattern. ये picture है. Now the next CT scan does not look, in the next CT scan does not look so bad. All you see is some haziness in the lung base, peripheral haziness. दिख रहे हैं? इसको बोलेंगे ground glass opacity. उतना सफेद नहीं है जितना निमोनिया में होगा, so we'll say ground glass opacity. कहां पे? Lung base में. So why this is lung base? Because we are at the level of the heart. This must be the lung base. So here you have basal ground glass opacity, but the area right next to the pleura, the area which is right next to the pleura appears normal. प्लूरा के साथ में जो एरिया है वो नॉर्मल है. यहां पे देखें बच्चे, यहां देखें, ये एरिया नॉर्मल है, उसके ऊपर बीमारी है. दैट मीन्स आई एम गोइंग टू यूज अ टर्म सब प्लूरल स्पेयरिंग. Okay, this is called as NSIP. What is NSIP? Full form? Non-specific interstitial pneumonia. Again, here you will have ground glass opacities, basal predominant, subpleural sparing, NSIP. Okay. Traction bronchiectasis was dilatation of bronchi in the area of fibrosis. जहां fibrosis है वहां पे bronchus का dilate होना खिंचाव के कारण है. That is called as traction bronchiectasis. Okay. Now, can you guess and tell me, out of UIP and NSIP, which one has poor prognosis, which one has better prognosis? So we know now that UIP will have poor prognosis, NSIP will have better prognosis. Subpleural sparing matlab that in UIP the disease was touching the pleura, while in NSIP the disease does not reach up till the pleura, so we call it subpleural sparing. बीमारी में और प्लूरा के बीच में कुछ हिस्सा ब्लैक सा नॉर्मल दिखेगा, which is called as subpleural sparing. Everybody understands? Okay. Now, once you're clear with this much, I feel we can also look at a CT image. Okay, this is one image that today only I had shown this image in one of the YouTube videos. You might have seen that video. So today we have seen that ground glass appearance is seen in interstitial lung disease like NSIP. It is also seen in pneumocystis pneumonia. But in current times, if you see ground glass, what do we mean by ground glass? मतलब सफेद है लेकिन उतना नहीं जितना न्यूमोनिया में होता है. It is hazy. I will show you better. So please see with me. So when you see this here, can you see this peripheral ground glass opacities, peripheral ground glass opacities? This is the kind of appearance that you will see in typical COVID-19 pneumonia now. Okay, so this is what we see in a patient. Now the history will not say smoker, long-standing breathing difficulty. No, they will say a 2020 man in 2020. Okay, person in 2020. You will think of COVID-19 pneumonia here. Are you clear now? थोड़ा सा समझ आया? Okay, बेटा कोविड तो देख लेना जाने से पहले ना, क्या हो इतना 10 मिनट बैठ जाएगा, क्या हो जाएगा, है ना, बैठना है ना. So the key is not only in the image, we also look at the history. वो कह रहे 2020 में एक आदमी आया आपके पास, then you see multiple ground glass opacities. Happy Janmashtami everybody. Then you will think of COVID-19. Okay, like this, something like this. You will have haziness, this not very white but some consolidation, some ground glass in the peripheries is seen in COVID-19 pneumonia. Are you clear? Everybody understands? Okay, so this is, and if you want to see more of it, you can actually see this on YouTube. I've already, today only I have loaded a video on YouTube, Dam's Daily YouTube channel. I am sure some of you might have seen. On Dam's Daily YouTube channel, I have made a video on what is the radiological finding on COVID-19 and what all you should know as a doctor and a resident doctor also. So please see that on the Dam's Daily YouTube channel. Very, very important. For all the students who are appearing for exams this year in 2021, if you're appearing for an exam, please look at that appearance. Okay, look at my video. You will get a question from that video in the upcoming exam. Okay. Now I think we are already at the time where some of you would be about to give up. So what I will now do is I will leave you with my message for today. Anything that you want to do and achieve in life, we can call it as dream, but we cannot call it as goal. Anybody? Now, what is a dream and what is a goal? Okay, dream means that you want to achieve something, but when you make it time bound, भाई इस साल में पीजी का रैंक निकालना है, इस साल में I want to do it this year, now it is time bound, then it becomes your goal. And I will today tell you the secret of achieving any goal is, please break down your goal into smaller targets. And in your room, you need to have a checklist like this. Class notes, पढ़ लिए, एक बार और पढ़ लिए. DQB, रेडियोलॉजी का कर लिया. Okay, like this. Class test दे दिया. And whatever you keep doing, you will put a check mark there. What happens is, now this is the secret that most winners are using. They dream, but they don't stop at dreaming. They make time-bound goals, and they divide these time-bound goals into smaller targets, and they maintain checklists. So if you are able to maintain, this is what I told you in the beginning of the class, that today I will tell you about checklist. Checklist is a phenomena. It is a massive tool of self-discipline. If you maintain a checklist, you will be able to do better than others. And this small tool can help you top your exams. Now, if you notice, I will tell you, there is this man who was the CEO of Amazon's healthcare service. His name is Dr. Atul Gawande. He is the CEO of Amazon, which is the richest company in the world, healthcare wing. He is the CEO. This man, he went to Africa, and in Africa, they had a lot of hospital-based mortality in the patients. A lot of patients were dying in the hospitals in operations. Okay. He went there, and before him, the people who had gone with WHO, they suggested that in Africa, you should improve the medical education, you should make more medical colleges, which would take 10 years, 20 years, and massive amount of money to improve. This man went with WHO to Africa, and he worked there for some time, and he suggested to them that if we can make checklist for doctors and nurses in emergency, what they should do in emergency if a patient comes, what they should do in the OT, and they made a lot of checklists. And because of those checklists, they were all, people thought what would happen. There was a 40% reduction in mortality in there. And then they came to a conclusion that what we are thinking is that we will improve healthcare by medical colleges, by hospitals, by money, but actually you improve mortality by more meticulous work, by more self-discipline, so that you don't make mistakes. And that is where checklists are important. Okay, it is very important to understand that we need to make our own lists. If you want to do well in life, you need to have a weekly list with you. Every time I would get up, I would have on my phone, in my notepad, some lists that I want to do, and then whatever I keep doing, I keep deleting. Okay, so if you can make a chart in your room, it will have massive impact on your self-discipline. And before I send you back for the day, why is self-discipline important? Now tell me. It's very, I am very impressed by this man. Tell me now. Now tell me, why is self-discipline important? Self-discipline becomes important once you become moderately successful. Try and understand, beta. आप already successful category में आ चुके हैं. You are now becoming doctor. Now what happens is, when you become moderately successful, people are no longer strict with you. Okay, when you are moderately successful, now your parents are not actually forcing you to study. Your teachers are not actually saying, "Pad nahi to murga bana denge, class ke bahar nikal denge." Nothing is happening here. So there's nobody strict at you, because you're already on the moderate successful zone. You are an adult, and people think that you know what is to be done. But what happens is, this is the place where some students, they become chaotic. Okay, and they start spending their time on Netflix, on computer games, on Instagrams, and they forget that their main goal. You will be most happy when 10 years later, when you are in your dream specialty working, and you will be, the true joy will be there, but you forget, and you start getting into chaos, and people are thinking that you're adult. What you need is actually self-discipline. But how to enforce self-discipline? You need to have a checklist. It's very, very important. So very, very important. Please have a chart in your room and keep making your list and keep cutting what you have done. Thank you very much. I wish you all the best, and I will see you again in the next class day after tomorrow, and we'll talk about more about lung diseases. Thank you very much.